بنزلهم على الويب سايت anyone want to review them will be fine. طبعا هذا اسمي حمد السيوف، انا basically a consultant child neurologist، بشتغل في التريننج تبعنا neurologist with special qualification in child neurology. زين؟ طيب what is spasticity؟ يعني الspasticity زي ما بتعرفون اياها it is velocity dependent increase in tone في the muscles ها؟ والstretch reflexes. عشان هيك احيانا when you do the tendon reflexes is hyper and the muscle is hyper excitable. A lot of the time it is velocity dependent. Sometimes بيجيك مريض انت تفحص المريض هذا he's not spastic. When you do it quick you will feel a catch. That is still spasticity and this patient still can benefit from Botox. طبعا and you guys definitely know this one. The neurospasticity can be devised as increased or tightness in the affected muscle يعني in the layman language. وتعرفوا السبب الرئيسي انه انا المين input output from the brain is inhibitory. فعشان كده when you have a patient who is less than 1 year, sometimes you might not find spasticity or hypertone. But between 6 months to 1 year, you will see that the patient starts to become more and more spastic. Now, the inhibitory output that comes from the brain, you lose it. Once you lose the السلطة المركزية, okay, the periphery or القوة الميدانية, it can يعني fire in unpleasant way. طيب. What is the problem with increased in spasticity? Why spasticity is a problem? Okay, sometimes it's a beneficial. You know, it's a lot of the time we need spasticity, but to a degree. The kind of spastic chest wall, and this is one of the most ignored muscles. You will see, and there is a problem with pectoralis, to raise the arms to the side, or put them on the clothes. Given I have to use this one. The elbow flexor definitely this is you can't make it straight, ما بتخليه طويل. Worse than that is if it lifts for a long time you can develop fibrosis. Okay, and we'll talk about the complication for untreated long time. The finger flexors, as you guys see, flexor digitorum superficialis and the profundus. You know the fingers will be like this. The hand or wrist flexor, ulnaris and radialis, the hand will be like this. And this is all can be treated. The hamstrings, they will give you a crouched gait, like a طفل ماشي بس he is crouched, okay? Will definitely the quadriceps toe walking, لا عفوا the calf muscle toe walking. The quadriceps I did not see it much. I probably have 2 patients. It was very difficult to do physical therapy for them and flex them. So don't get surprised. You know, there's no 2 patients are alike, okay? Well, inner thighs, of course, the adductors. I injected, Ahmed might remember, we injected 4 or 5 patients who are in their 70s in Saudi German hospital. Wallahi, 2 or 3 people we were not able to open their thigh.
Yeah.
To the extent, يعني لدرجة إنهم صامتين they can't clean them. يعني I can't. يعني that patient would be great teaching patient. And you can feel the adductor just like a rock. This like a rock. You inject 100 unit. You inject like 150. It does not work that much, but it opens. Okay? But you know this is more of a palliative care. Now, the upper extremity spasticity, as we talked, the flexed elbow, okay, and flexed wrist, flexor digitorum, flexor carpi ulnaris and radialis. You have the pronated forearm. Please, guys, I want you to pay attention to that. This one, this muscle, it's one of the most ignored muscles, pronator teres, here. A lot of the time, the kids will be injected everywhere except I hardly ever seen somebody injected in the pronator teres. I always look at the pronator teres because the patient will be always like this. With the supinator strap, he does a great. Now, عندك الهنج fist, as we see here, you know, this is the superficialis profundus, plus you know the thumb muscles, and also the flexed elbow, as we talked, the thumb in the palm. There's 2 deformities: adducted palm, or this one. Now thumb in the palm. ABB, you inject here, and this one, what do you inject? Adductor pollicis. Here come adductor pollicis. Here come adductor pollicis previous. Adductor pollicis previous. okay? So always remember this one or this one. It's very, remember when you inject, they diffuse. Especially in the kids, because they have small muscles, they diffuse. But if you can target the muscle, it will be a lot much easier. Huh? Lower extremity spasticity. Of course, the main thing I see is the equinovarus. Everybody saw, and we saw it with Ahmed. You also have the toe going up. I don't see it much in kids, to be honest with you. And the flex knee due to the hamstrings. Ahmed, we saw it with Ahmed. And the adductor thighs, that's very common. It's a hygiene problem, and it's a lot of the time these kids who are very tired, they don't even know how to sit because they can't open their legs to sit. Okay? A lot of the time, this muscles in patient who is even debilitated, or his patient, you know, he's gonna die, like he's 78. You need just to improve his hygiene. And it's literally, sometimes when I talk to families, they will tell me, doctor, 2 or 3 of us will try to open his legs and we can't. It's a pain, it's a nightmare. When he starts to smell bad, he develops infection, ونزيد الطب. So that's muscle that we need to think about. The spasticity. Some of the people will tell me, and a lot of the time the family will tell me, why do you want to inject it? First it's going to take 3-6 months, and after 3-6 months it will go back to its own position, right? تعرف المكبس? You know the spring? Zumba. The muscles, when they are spastic, زي زنبرك المضغوط. Okay? And the muscle is tied on a bone. مربوط على العضل. Okay? So what will happen? First, this bone can't grow well. عشان كده, a lot of the time, when you look at these kids, تلاقي إيده أصغر من إيد الثاني. Okay? One. Second, he cannot use the muscle well. Third, he cannot use the joint well. So this will lead to the joint deformity, right? On top of that, this one, he cannot control his muscle. So cannot use his muscle in the right way. The bone would not grow. He will develop fibrosis, and he cannot use the joint. Okay? For kids, we inject him, they stop walking. I have a kid in Abu Dhabi. We injected him 1, 2, 3 times. She stopped walking. Yeah. Because the pressure, the pressure, just like the stab. When you are pushing the pressure, when you leave the pressure, the muscle is more relaxed. You can use a lot more. You don't need them to be high potent. And if it happens, it's not a problem. Believe me, it happens with me all the time. I tell them this is a good sign that they are responding really well. Next time we give them half the dose. And we always start low and go slow. This is the key point here. طيب شو الهدف أنا لما أعالج مريض? What is my goal from it? Improvement in position. That's what. Help hopefully to make him more mobile or walking. Sometimes it's painful, cramps. It will help, and there's also studies, a lot of studies. I have a book, even a total book written about spasticity, about pain and Botox treatment for pain. Contracture prevention. And my son, contracture. How do you see? Once you get a contracture, you have to do casting with Botox or serial casting, and not many people does it. Very good surgery. And surgery, I have 3 kids, wallah, done surgery twice. Because every time they do it, they leave them, they get tight again, they do it again. Okay? And of course, easy of care if possible. Okay, now what is the therapeutic management? When do I need to use Botox? When do I need to use oral baclofen or oral diazepam? I always like to have a goals or rules, because this helps me. And rules always help you, how to do that. If you have oral medication, you have nerve blocks and chemodenervation like Botox, you have orthopedic procedure, and you have intrathecal medication. Okay? Now, when do I choose oral medication? The rule of thumb, if more than 4 big muscles, if I am dealing with more than 4 big muscles, I have 2 adductors, for example, 2 hamstrings, 2 calf muscles, 4 and above, you might go for systemic medication. System. Give him baclofen, give him diazepam, but you know the complication, you know the limitation of the medication, and you know the availability of the medication, right? Now, second, if I have 4 or less muscles, I try to go to Botox. Botox is best for the focal spasticity. Lovely. Now, can I use systemic plus Botox? Of course we can. This patient is very spastic. I give him medication, he got relapsed. Everything is doing well, but this muscle is still spastic. Then I go ahead and target this muscle فأنا in this way I decrease the number of the muscles injected, okay? And I decrease the pain and decrease the cost, okay? And sometimes you put them in medication, they become like a zombie, 24 hours, drooling, sleeping, and not interactive. Or you put them in baclofen, and honestly, my experience with baclofen, yani, it does help, but it probably work, correct me if I'm wrong, probably it works 40 to 50% of the time. That is my experience. Now, orthopedic procedure, of course, as you said, with casting, serial casting when you have a fibrosis, or if you have a severe spasticity, you can use that to augment the Botox. Intrathecal medication and the baclofen pump, we have done it for 2 or 3 or 4 kids. The problem with it, it's a bit one. Second, it's very expensive. Here, once you do it, you can back it off, right? Yeah. 2 patients, we put a baclofen pump when I was working in the Mafra, and they got called and told me they did not respond. They did not improve. I'm skeptical. I think they might have improved, but they did not have the right person to manage it. The limitations of expertise to manage that. That's the problem with the baclofen pump. And of course, it's mainly for the lower extremity. That's what they claim it might. It might help the upper extremity, but there's people who baclofen pump work for them like a magic. Okay, but today we're going to talk about Botox. It's a lot easier. And this is based on my experience. A lot of the time, the mom come to me. I tell her that, okay, we injected the patient, and we put the patient on medication, and we tell her, how's your son's doing? Give me the temperature. Well, there's no improvement. There's no improvement. No. The last case I did, she has a 7-hand career. And like this, I videotape it because sometimes I use for presentation. And I put her in the back. Then I saw her like after 3 weeks. And the kid was sitting and no shaking at all. And I told the mom, how do you think your daughter's doing? She said, Allah, there's no problem. I said, are you sure? هي من العين. بجيب مرة ثانية. I said, are you sure? No, I don't see problem. But can I show you the video? So I show her the video, and I show her that well, she improved a lot. Told her because you get used to it, because you see her. For me, it's not. But if you are guys really wanting to do, just use your iPhone or Samsung, videotape him, download it, keep it, inject him, and next time videotape him or show it to the family. To convince the family, especially when the kids start crying, and that your son is improving. If they don't see a big improvement, believe me, they're not going to come back to you. Especially with the cost, right? That's my experience. طبعا you have to have a specific goals. What I see sometimes people in the private. Hamstrings, gastrocnemius, pronators, chest muscles. He was injected everywhere. That's not goal oriented. What is my goal? I have a problem with, for example, walking. I want to correct that. They target this muscle. Not every spastic muscle has to be injected. Not every spastic muscle. So they inject them everywhere. So you need to have a goal. What's my goal with Ahmad? In the right side. Now his left side is affected. But the main problem with the right side is flexed. We will try our best to make this muscle open. He's also flexed the wrist. We try our muscle, our best for his muscle here to open like this. Okay. And his hand to open, okay? That's one goal. And the hamstrings and the gastrocnemius. Now, that is add-on. What do I mean by that? If I inject him today, he improved 20-30%. With the physical therapy, we inject him next time, we'll get much better. And he can build on that. Don't think every time I inject him and leave him, he'll go back. No, he will jump, and he go down a little, and stay here. And he will jump bigger, and bigger, and bigger. Until he become more eligible for more definitive therapy. Okay? Okay. Of course, exercise is very important. Physical therapy, occupational therapy, I think in kids it's a problem. And Dubai, honestly, I see a big problem, a big need for physical therapy and occupational therapy. Okay? Yeah. Botox, it is something that not, it is something I'm not, newly introduced. Okay, it's FDA approved long time. Now, this is in 2008 assessment of botulinum and neurotoxin for the treatment of spasticity and evidence-based review from American Academy of Neurology. What they will say, botulinum and neurotoxin should be offered as a treatment option for treatment of spasticity in adult and children. Should be offered. When was this? 6 years ago, right? And we are still don't have probably, like, we only have a few injectors here. Now, the practice parameter in 2010, they also emphasize the same point. If you have spasticity and if it's focal, please offer him the botulinum toxin. When was FDA approved? 1989. 89, and almost now, how many? Like 17 years, 16 years approved, and still we are dragging our feet to use it in our industries. Now, we are using with Botox the botulinum neurotoxin type A. It's a focal therapeutic, it's the best as a focal therapeutic medication. Why? As we said, it is, you should inject it directly in the overactive muscle. Okay? What will this lead to? Reduced contraction, relaxed muscle, allow more normal growth of the muscle, allow better response to PT, more normal use of the affected muscle, advantage of local injection. It is target effective and it's bind there and hardly ever leak. And they will give you the main rules when we inject what we need to use. You know the mechanism of action, the prohibition of presynaptic release of the acetylcholine. That's a very long term, yeah? And you see this is what we are talking about, botulinum toxin, preventing acetylcholine, to be released in the synaptic cliff and reduce the spasticity. And this is it's a basic, it's well known since probably the second year for medical school. Now, dilution. This is here. If you look at this table, they will tell you dilute in 1 or 2 or 4 or 8 or 10. What do I use? I'm not here to review 300 or 400 articles and take 200 expert opinion. I use 1-to-1 dilution, 1 milli to 100. Majority I use 2 ml per 100. Okay, for kids. And if I am injecting, for example, if I'm injecting torticollis here for a kid, I'm not going to use 2-to-1. I'm going to use 1-to-1. 10 colors. Theoretically, it's very safe, but theoretically, the more you dilute, the more it will diffuse. That's it. Theoretically, okay? So I use in kids. In kids, 1-to-1 or 2-to-1. 2 ml per 100, okay? And this will give you how much? If you use 1 ml, 10 units per 10 units per 0.1 ml, or in 2 ml, it will give you 5 units, okay? Now, in adults, the articles I wish I knew that it's mainly began. The article I will send to you guys will tell you how much you inject total. Rule of thumb: 10 to 15 per kilo, 10 to 15 per kilo for each kilo. First injection.
10 to 15 units.
First injection. Now recent evidence they can go up to 20 to 40, and they can inject that. But if you are a new injector, if you want to be on the safe side, 10 to 15, don't exceed more than 300 units per 1 session. يعني عندك طفل عمره 5 سنين ووزنه 50 كيلو. You're not going to give him 500 units, right? Right? You're going to give him 10 to 15 per kilo, but maximum 300 per session. Don't ever inject more than 50 units in 1 spot. Why? Theoretically, this may increase the diffusion and it go and cause systemic problem. I have never seen this. And even the doctor I worked with in the States, his name is Dr. Taylor. He injects like a huge number of patients. He told me one time, I injected a patient and he got me. We admitted him overnight, we observed him, and said, everything was fine. Okay? I told him what was the maximum dose we have ever used. He was adult, 1200 unit. 1200 unit, يعني قديش 12 علبة 12 bottle on 1 patient. But this is the maximum dose he ever used. Okay? الآن as you see, no more than 50 units per site. Localization of the involved muscle with EMG guided nerve stimulation is recommended, especially if you are going into neural sensitive area. And then kids, luckily we don't do that much. Lucky. And don't inject more frequent than every 12 or 13 weeks. They said that it might trigger sensitization. Okay? So I never ever inject less than every 3 months. 3 months in an injection. Most of the kids between 3 months and 6 months. This is for adult. Bicep 100 units to 200 units divided in 4 sides for adult. Flexor carpi ulnaris 12.5.
It's for adults.
This is for adult, yes.
For pediatric.
I'll tell you. Flexor carpi radialis 12.5 to 50 units, okay? Flexor digitorum superficialis, the same thing, 30 units up to 50 units. لاحظ انه these muscles, the more you go distal, the smaller the muscles. In kids, what I use, there's a goal. Small muscles here, you give 5 units. Honestly, I give for small muscle, adductor muscle, 5 units. I give 10 units myself. Okay? Small muscles here, I give 5 units. Muscles of the forearm, around 15 units to 20 units. Okay? Including the pronator teeth. Here, you can give up between 20 to 40. Depending on the muscle. If the muscle is like this, I'm not going to give him 10. I give him 40 units. It's better in 2 sides. Now, one thing I want you to pay attention to. This is bicep, right? You inject the bicep. Don't forget to inject the brachialis. It's underneath the biceps. So the brachialis, you always need to inject the brachialis and the biceps, especially if it is too hard of a muscle. And this you will know the more you inject, and this is all it will be explained in the article. I will send to you.
Doctor, is there any scale of spasticity that you are using to?
Yeah, that's a good question. They use Ashworth, they use gait analysis. I don't use it. The best thing I noticed is the video. When you take the patient, inject him.
You want to know how much is the dose? How much is the dose? You said between 20 to 40. Well, 5 depends.
Yeah.
It depends on the spasticity. في any scale that you are using to determine?
No, I will lie. It's more of experience for me.
Yeah.
Because I inject, but there's a lot of people, they use the Ashworth. And Mafra Hospital, when I was working with Dr. Wasim and the Dina, they were using the Ashworth and how tight is the muscle, how stiff is the muscle. But you always go for, in general, for the lower range, for not very spastic muscle, okay? 10 units, okay? If it is very spastic, I go 15 to 20, right? And when it's very spastic, I will tell you what's the challenge, how will you inject it. If it is not spastic, very spastic, I go to the lower dose, 20. If it's very spastic, I go to the higher dose.
You mean 5 units more or less, it's not a problem?
Absolutely not a problem. Okay. And this is absolutely, you are not dealing with a phone number. If you change number, you are out of the country. Don't ever worry about it. And because I have been injected so many, don't even worry about that. This is also still for adults, and they will tell you the dose for kids. Side effect, I rarely see. I think the main side effect is the being scared of a needle. That's why I give them dormicum. And about giving dormicum. You give them dormicum, they relax, they start smiling. I still remember a kid every time I inject him, he start laughing. To decrease the anxiety and decrease the pain of the needle. I hate needles myself. Okay? But when you, especially if you are going to inject too many muscles, he will be relaxed. Now one thing is your trick. If you relax him too much, you may lose the tone. So you have to take your time, to isolate which muscle you are injecting. Okay? Right. How do I identify muscle? EMG, lovely. Have you ever did anybody of you guys an EMG? EMG. Have you ever used it?
No.
The needle is very hollow from one side, and when you inject it in a spinous muscle, it bends, and it's pain to get it in there. And this is the doctor I work with, so I don't use EMG. Unless we are going for very targeted small muscle, even here I don't use EMG. I don't use EMG. I used to use what you call noise box in the States, and it was not very helpful to me. Okay, because the muscle inject are mainly muscle big, and you can hold them with your hand. And you will see when you go in the muscle, you feel you are in the muscle. It's fast. Of course, for EMG I don't use. Now we will be doing we are going to have a new machines. What do you call it, Ahmed?
EMG machines. I have one actually. I could
Right.
bring it and show it to you.
You know.
I have one, yes, in the car. It's a small portable EMG machine with a stimulator. So I could get it and maybe bring it.
That is, we're going to do, we are going to do another workshop later on.
Yes,
And we'll
exactly.
show it to you
Yes.
guys. But more for me, if you ask me in your practice what do you use, I don't use any energy.
Use your
I use my hands with time, and with time, as I told you, guys, you're going to get very comfy with that. It's because it's very simple. And this is Mr. EMG. He's injecting with EMG. A general rule, never inject more than every 3 months. Never inject more than 50 in one side. Dilute it up to 4 ml in kids, up to 2 ml, don't go more than that. Unless you are dealing with like, a big kid, okay? And a big muscle. If the patient, you inject him and he's having severe pain, I replace the normal saline with lidocaine, okay? To be safe, on the safe side, the first session don't use more than 10 to 15 per kilo. And this is all gonna be, guys, explained into the article we'll send to you. Now, this book, okay? This book. If you want to learn Botox, okay, you don't read my house. You open the book, this book, especially this book. What you need toxin injection line. You open it, and you put muscles. Okay. Where's the injection technique?
We have other books.
Yeah. We have. Where's the injection technique? The lovely thing about this one. The lovely thing about this one, you can use it for kids and for adults. How to isolate the muscle, how much to inject in each muscle, and if you see a deformity, what is happening with this kid here? It's twisted out. They will tell you most likely. And the good thing about it also, basically, it will tell you where to inject. First time, once in the first 3, 4, 5 times you inject, you will, guys, need this one. This one. Lovely. That's my favorite. That book is good, but it's not near as good as this one. I love this one. Okay? Absolutely. That's يعني ايش دوز؟ السلام عليكم. أهلا كيف الحال؟ أهلا كيف الأمور؟ أهلا مرحبا. أهلا السلام عليكم كيف الحال؟ تفضل. So every time we need to inject, I will use this one. Prepare for your patient before you go there. Okay, so you have ready. Another things you wanna do, basically, will assist these kids. What I will do also that might help you so you don't get confused. I can tell you one experience with me having in the States. Piece of sheet, okay? You know the cover of the bill, the ragged towel. Mark his leg, right or left, and when I'm gonna inject in his right hamstrings and gastrocnemi. I draw 50, 50, 25, 25, and first few sessions, please don't put all the medication in one syringe. Yeah, don't dilute to 2 ml and get the syringe. Okay, 0.2 ml, I'm gonna inject 0.2. The moment the patient starts crying, and you're gonna get excited, you're gonna put it there and squeeze it all in there. And they have seen it happen. Okay, so isolate it. Put it in 4, I need to inject 4 sides, put it in 4 needles. I have the diagram in front of me, okay? I'm going to inject here and here and here and here. Even if you get excited and you inject it, at least you are injecting 1 or quarter of the dose. Please label the kid side you're going to inject. One time, that's happened with me. And it's not shame to learn from our mistakes. Before I used dormicum, or the mom refused to give dormicum. And we hold the kid, and the kid was super duper anxious. He was crying, rolling over. Finally, we draw him down, and we have 2 hefty nurses on his back, okay? And the mom was crying, and we pulled his lip, boop, boop. Alhamdulillah, it was done. It was done on the wrong side. We injected right instead of left. So I told the mom, oh, we did a mistake. She told me, I don't blame you after what happened. So from that day, you can silence it. Label the leg, please. Try your best to give a sedation. Make sure you draw a map for the patient, where to inject and how much to inject. Please don't put them all in one syringe, okay? And don't be scared to inject. It's extremely simple. And I'm talking because I have done so many times. And looking back when I started, I thought it was really a huge big deal. And now after injecting, let's say after 2007 till now, 7, 8 years injecting adult pediatric, it's extremely significant. And on top of that, you need your own guidance. Now, that is this book, and there's this book, Anatomical Guide for the Electromyographer. This one tells you how to isolate the muscle. And for preventive, they will tell you a line bisecting midway between the bicep tendon and medial epicondyle, 2 finger widths, you put it here, you will get your prenatal tendons. With time, of course, when you inject it 10, 15 times, you don't do it anymore. But at least for the first time, have it with you, prepare, before you see the patient, prepare, the day before or 1 hour before, write everything, give them medication to be sedated. I don't put them all in one needle. Isolate like a horn 10, I put 10 here, horn like 50, I put 50 here, horn 100, I put 50, 50. Okay? Don't put more than 50 in one needle. Okay? So you do this all help you initially to tackle all these issues. And then with time, it will be simple, and I will remind you. Okay guys, في عندكم أسئلة, questions, comments, يعني عصف فكري, سؤال, أي شيء.
The article, this is it available as an ebook?
It's Amazon. You can download it Amazon. If you want, you can buy it and download it Amazon. Or if you guys want, you can handle it. If it's not available, you can ask Ahmed to make a photocopy for you, or order it for you, or order for you. But a lot of time I go back and look at this one.
Do you mind if I take a photo?
Absolutely, no. This one. Yeah, I will send you the PowerPoint anyway.
Thanks.
دكتور لأي مرحلة نقول جرح العضلي البوتوكس injection؟
3 to 6 months.
But
how much?
Severity.
Yes. I have patients who you can get them back to almost normal. And they have one kid now in Abu Dhabi who is hypertonic.
Right.
What's been hypertonic? We give him the dose. Like, let's say like 50-50, 25-25, it does not work. We bump it up to 50-50, become the muscles, they become the hypertonic. Don't worry about it. 3-6 months, it will go away. The good news, 3-6 months, it will wear off.
But it will go away, but it will be coming back to the previous status. Like if it's 100,
right.
We inject now it's 50. After 6 months, it will be coming 100 or like 70, 75.
Wallahi, what this depends in one fact. The patients are doing really good physiotherapy, okay, and they are religious about it. Usually it will go back, but not near as bad as the old.
Yeah.
You will definitely see that. No, he's better. Okay, that's why you are building up. When you inject one time and it's not working, you go up higher in the dose, you will notice it's more responsive. Because remember, the muscle is not crushed as before.
So we can inject again and again.
You can inject every 3 to 6
For
months.
how many times you recommend?
Okay, the orthopedicians will tell you, keep injecting until you get no more results. What we tell them,
There's
inject.
no contraindication. Yeah.
Absolutely.
Repetitive injection.
Absolutely. Every 3 to 6 months. A lot of the time, we'll tell you inject until he is near, his puberty time. Because at that time, the bone and the muscles, are almost, their adult height, and then you can do more contact procedure.
Yeah.
Okay, but you can inject, and we have patients that we are injecting for years.
Yeah.
They're telling me I work with them, they're injecting for years. Okay. Summary. It is really very safe. It is really just, it's very simple to inject. Make sure when you inject, don't inject more than every 3 months. Don't give more than 50 units per injection. Don't give more than 15 per kilo for a kid. Maximum 300. Okay. If the anatomy is messed up, the kid is very spastic and the anatomy is messed up, don't worry about it. Correct put it in the anatomical position. Inject to relax the muscle. Whether you are injecting in the adductor or in the other muscles, all they will diffuse and relax. Then you will be able to inject better next time. Make sure you continue with the physical therapy. Use the adjunctive service, physical therapy or casting, okay, which is also very important. And make sure you observe the patient and tell them about the side effect if they are becoming excessively weak or drooling or breathing problem, which is luckily, alhamdulillah, we never had. before because it's very safe medication. What is the contraindication? Or what is the, why do we, Botox sometimes not everybody uses? Because it's an injection, it's a little bit pricey, okay? And also, it needs time and it needs an expertise. But once you get used to it, inshallah, it will be fine. My phone will be with all of you guys. And the people the physician, my colleagues, we did train them in Dubai. They always call me, doctor, one of them called me, oh, the patient is in front of me. Where can I need to inject this muscle? I told him, you should have told me probably 5 minutes earlier. Not now. Why do I need to inject the patient? Where did is the patient in front of me? So I always, we can save your number, you can call me and tell me, and you always can, chit chat and provide you with the support. Okay? Ahmed, أنا لديك أقوال أخرى يا أحمد.
أنا fine.
Fine? Okay.
So shake it.
طيب.
You want to take a look at
Yeah,
the
please.
EMG?
Show to them.
Yeah.
طيب. Tips for Botox. أنا آسف جدا أكثر Tips for Botox. Now, to know this is the real Botox, it should be Botox. It has, each unit has 1 handle. That's the only, this is the only Botox we have, 1 hand. Always you need to look at the bottom. There's a white precipitation. That white precipitation, guys, this tell you that's a real Botox. It's under negative pressure, okay? Always use a bigger needle to put to dilute and to withdraw. Because if you use the small needle, it will be painful. Now, I will tell you one thing. I would not do it, and they would never do it. One of my attendants in the state, she used, the Pepsi can opener? She used to open it all, put the water, then throw. But if she dropped it, and he's not going to give it to her.
We have 5 milliliters.
For dilution, do you have a full swab? For dilution, I use 23 gauge needle. I use 20 gauge needle because go in and quick out. For injection, please do me a favor, I use smaller needle. Use 25 gauge needle. 27. We have 31 gauge needle for the face. Because it's not big. Perfect. So this 25.
This is 20.
This is the smallest you have. Okay, so what I will do, do you have one swab?
Yes.
So, of course, the general hygiene. Now, when you draw, I want to dilute in 2 ml, guys, but you will notice that you always never get the same 1-to-1. So what I do, I withdraw 2.2, 2.3, okay? Because with that dilution, all what you're going to get, so I would go, for example, 2.3 ml. Now, what do I mean by negative pressure? Look, I want you to watch that, guys. Look. If it is not doing this, it is made in Dragon Ball. Give me a call, please. And don't get surprised that it is not working for your patient. When I do it, I don't shake it like a Pepsi. I just, roll it like this. Why? They will tell you if you shake it hard, it will denaturate the body. So my attending used to tell me this, grab it like this.
It's a protein, yes.
Protein. So don't shake it, or if you have an aggressive nurse who is talking to somebody and she's shaking it, good luck, it's gone. Now, when I do, what I do, as I told you, one of my attendings opens like a Pepsi can. Put the water, withdraw. I would not do it. What I would do then, I would withdraw. You see? It's painful, right? So what I do myself? You will see. You got the negative pressure.
You need that pressure off.
And when I draw, what I will do? See? Lovely. Perfect, right? That's the perfect. So I want to push it back. Now we're going to prepare, we need the needles, small needles, if you don't mind. What's that? 20. Okay. Now, we said, according to our protocol, we need to use how many needles? 7. So we need 35. So 35 here, how many?
Sorry?
Here, 2 dilution, 0.7 ml, right? So what I will do, I go here. We should have all the products. We should have all the products of that. So I will do this is, you can do that.
So now he's turning to the other side.
Huh?
Can you make it outside?
One side.
خلي
والله
Right, high point 7. This is the way for the gas to clean up.
I guess.
You need, how many need you?
sorry I have that
Yeah, big.
There's two sides because it's 3.5.
35 حسب الحسبة اللي حسبناها.
معلش دكتور الحسبة بس مع الثاني.
Yeah.
عندي 100 2.3 ml.
حسب حسبنا. Yeah, 2.2 ml. I give extra 0.3 ml, so I get 2 ml.
Yeah.
Because if you put 2 ml, you will get 1.8 ml.
Okay.
Okay? So احنا حسبنا 35 صح؟
Great.
25 25 right? Okay? That's what we decided to do, right? So بدنا واحد نيد اثنين نيد ثلاثة نيد أربعة. صح ولا لا؟
صحيح.
35 a double dilution is 0.7 ml.
Okay.
That's one for one side. Okay? And then I will put another one for one side. Huh? Okay? Clear?
يعني 0.7.
35
0.7 هذه 35 international.
35 yeah.
And double dilution.
Yeah, yeah, double.
One dilution 0.1. Yes.
35 على
Follow
5
the one.
Really, this is so we can prepare it. I think we were very used to it. Now with time we'll get used to it. That's why prepare your first 2 times. Get everything ready before the
visit.
Take your time. The thing I used to work with in the state, honestly, what he used to do, just fill the names, go ahead and prepare 1, 2, 3 under double dilution. And she'll do it for you. But he injected maybe 5, 6 weeks. So how many are we going to get here? 0.7 now? عشان الجهاز بكلمه ولا؟
Yeah.
طبعا الجهاز بيصير مش وين ما قاعد ينجح. We could have injected for 15 minutes. الجهاز بيصير typically we inject for 10, 15 minutes.
You will inject UPS.
To nothing. We will focus on the meat. We need to have this is going to be. About the 10H. Gas Piclamide. This is gas Piclamide. Okay. Now we need how much?
0.5.
Another 2.5.
All right. We need that one. With the 7. عندي نسبة كام؟
0.5 to us.
عم بخمس.
لا خلاص
هذا هسه.
استغمال
أخذ 4.
حلوين حمودة
I go to 5 طبعا كان الهامسترينج. احنا 35 35
25
70 فلا ما يكفي يعني اوكي؟
You need the other
I need the other one. The other one we use the bigger needle here, okay? Always we give extra, we always give extra 2.3 ml, right? So make your dilution start with 2 to 1, huh? So I usually give them 2.2, 2.4 ml because we are going to use some anyway, right? Negative pressure as we said before, like this. Always try another tip to put it to the side, okay? So it does not hit the protein itself. Does not hit the protein at the side. And when I do it, I do wrap it like this, small, gently, lightly, lovely, like this, okay? Then I will take this one out to release the air because it will be a lot easier to withdraw. So either two gas filters, hamstrings,
Another 0.5.
that will need the syringes, this one. Keep this like that. Make sure you don't get messed up while you are doing this. So, and how much we need?
0.5.
0.5 حتى نخلص من الجرم اللي تحتها. So what I will do, I will pull 0.5 and 25 ml, huh?
Yeah.
25 ml, huh? Did you guys see how we calculated it? It does not have to be any perfect.
Yeah.
يعني على المستوى الديكارت يعني they have to do it to be perfect. This is خلصنا من الجرين. هذول جاهزين لو يهمونا. They are ready for.
hamstring.
خلاص this is diagnosed, this is hamstring. So when you inject, you have hand me, pop. You can put underneath them and you go. Now we're going to make how much? 40 meat, 14.4. Now this old one. And here we need how much? 0.4.
للبايسبس
With brachials, huh? This is 0.4. Put the middle one. We need another 0.4. Have a ring. Brachials, huh? Brachialis. We're going to do this one. 0.4. So even though it takes time with you, but initially at least will decrease the risk that you're going to go through the first time, huh?
هذا طبعا كود
كود
يعني تقريبا كم البروسيجر كم
كم قد ايه؟
تاخذها من الفريج مثلا ولا من الباك ربع ساعة نص ساعة
Now usually take it out like 5 10 minutes.
Okay.
But if you want to take it 30 minutes, that's fine.
If you want to prepare and get things so
Absolutely,
until the
30
patient
minutes is fine.
arrives.
Absolutely fine.
And after you prepare it, you can leave it for the
طبعا air conditioned room temperature 20 22 23
So this one خلصنا احنا ايش؟ biceps.
Brachials.
We're done with the brachials and the biceps. That's lovely. And what we are left with, we're gonna present the 10, 10, 10, 10.
So 0.2
Right.
Which is fixed carby, alnaris, radialis, and pronator.
Pronator teres, and that's it. That's what we
Three,
did.
10.
Now we are not gonna go for each one. We see we're gonna do 10, 10, 10, pronator teres, and leave it because he's so thin and so it's fast. Okay. So we will withdraw 10, 10. We lift here, I think, so 0.2. Okay. This is how much we're going to utilize. 0.2. Double dilution. And I would advise you guys probably to stick to one dilution. It will make your life a lot easier. A lot.
this dilution.
Stick to it. So it's become standard. This is for one. For 10, one of the 10 we're going to use. Yeah, that's fine. We don't have more, probably can use the other one. At least we can use the big one. And this is another 10. Okay. We need to use this.
البوتوكس كمان بتقدر تستفاد وبتقدر نتابع
الآن بالطريقة هاي أنا I tried my best to minimize the loss and minimize also the confusion. Okay, and you will notice that it will be a little bit maybe a little bit confusing. Yeah? If you want the rule of the thumb: don't ever throw any Botox away. Now, the company will tell you it is for 24 hours. If you don't use it, throw it away. Don't listen. So you don't listen to them.
عشان يبيعوا.
لا هو يعني حتى يعني هم believe they are يعني أنا I work with them. They actually work with them. Yes, but sometimes keep it. Even patient who does not have money can use it. You can use
There's
it.
always a buffer in time. Like I said.
Whatever is left over, pull it, put it in this one, put the label and leave it. Then when you feel even after 2 3 weeks or so. That's what I do. يعني بجمع لك من كل مريض مثلا محتاج وده بس like 10 units. في مرة أنا انجكت only the 20 أعطي 20 unit here or 10 unit والباقي أكيد. I'm not going to throw it. Okay. الآن we come to the front part. Okay. خلاص. For this one, we're going to have to use this cover. Now for the potato trees, we can use a shell sword. Potato trees, this one will be. Okay? And guys, we are good. Look how I am organized here. I want you guys to look at organization is very important. Gastric pneumonia, hamstrings, biceps brachii, brachialis. It's a big dose wide. He's very spastic, right? And this for, as I told you, 10. I'm not going to go inject here and inject here and inject here and do this one and inject here because he's so thin. The muscles are overlapped. I put them in anatomical position, thin. Okay? And
without auxiliary.
without that.
Just.
Did you see this one? No. Now for you, no, go for Dr. Talib, right? What I would do, flex torum superficial. What's my finger here? This one. Okay, right? That's one. Flex torum profile. That's what I do. Finger bridge here. I go here. Okay. Okay. If it is for the flexor cardi radialis, 4 finger braids, a little bit more lateral. Huh? It's all right? Flexor cardi ulnaris, 2 here and here, 1/3 here. Okay? But for this kid, try to isolate it. It will be painful. Painful. Okay? حلو؟ حلو الانجكشن الطفل الثاني؟
لا الطفل الثاني مش هو عمل عملية
اوكي. حلو. فولنا جبنا